I was asked to talk about my practice, and I said, no, I don't want to talk about my practice because each of us have different needs. Each of us practice in different markets. Each of us have different outcomes. So what I thought I would do is, instead of giving you a micro look, give you a macro look. Give you a look that was fostered by one simple rule. If you want to change something, you start at the end and work backwards. You make a list of outcomes that you want, and you create a process that's consistent with those outcomes. And you've all heard versions of that today in everyone's own practice, and certainly in the last presenter. Very good presentation and very on target, focused and bang on. So I thought I'd talk about getting small in healthcare delivery. Because in essence, in a surgical practice or in a specialty practice, we really have to do what you've done with your own individual primary care practices. Now, I'm going to tell you one quick story for those of you who are still undecided as to whether or not to go into a direct pay or cash basis practice. My career started as a general practitioner in Ontario. I was educated at the University of Toronto, and I went into practice in 1975, and in 1977, the Ontario Provincial Police and the Ontario Health Insurance Plan people came into my office in front of my patients in the waiting room, made the declaration that they were seizing my documents because of suspicion of fraud. Now, I practiced in a mostly Italian-speaking community. I made house calls, and word of that spread around really quickly. I didn't know what to do. I had no rights. 2 weeks later, they came back, and they said, "We're sorry, we got the wrong Mitchell Brooks." I decided to come back home, and I went into orthopedic surgery. The lessons in Canada, however, were very helpful to me in kind of getting ahead of the curve. So I want to talk a little bit about how to deliver this, and I want to talk about operating principles. We function in a supply and demand environment, and right now what's happening is that the United States government is walking down the exact same path that Britain and Canada and the European countries have walked down. They're going to allegedly control cost by squeezing the supply side and doing nothing about the demand side. These are political solutions to a social and healthcare problem. There are no business solutions here. And basically, what is being done is a whole bunch of money is being thrown at a whole bunch of people, and nothing is going to come of this. So I looked at the U.S. system of healthcare today, and I love this picture because Gene Wilder is quite a guy. And I looked into the future, and I'm not sure what the future holds for us. But I do know that Peter Drucker was absolutely correct. Everyone who's sitting in this room creates their own future. Nobody's going to create your future for you but you, and you all know that, and that's why you're here. So I don't like whining and complaining like most of my colleagues in a surgical lounge. I like to look at the facts. What are the facts? What are we faced with? What is the environment in which we are practicing? Now, I initially gave this talk based on testimony I gave before Congress in 2009 for the healthcare law, and I took some of these slides and put them back in and updated them to 2012. We all know that in a couple of years we're going to have fewer doctors, and that's going to double. So what's going to happen is you're going to have an overwhelming number of people having accessibility but no availability. And it's going to create a de facto rationing of healthcare. Why? Because it's going to take forever to get seen. This is deliberate. It's been done all over Europe, all over Canada, all over the United States now. There are 12 million new Medicaid patients. That's greater than a third increase. And 1/3 of the surgeons who are practicing today in the United States are over the age of 52. And a lot of them, like me, who's older than 52, has said, you know, this is nonsense. I'm not doing this anymore. And I made this decision 8 years ago. Only 35% of physicians will be in what's called a private practice, and we're running very, very quickly to a two-tiered system of healthcare delivery. You sitting here are part of the better tier, the tier that will not check boxes, the tier that will take care of patients, that will treat patients like people, not like a number. Everybody else, they'll be working for hospitals and insurance companies. They'll be working 9 to 5. And as you've heard, healthcare will become a job and not a profession. And I think those words are very profound. And if you take anything out of this session, it is a very sobering thing to take. What does the Affordable Care Act do? It only funds 3,000 to 5,000 new primary care physicians in the coming decade. Communities are going to need 45,000 new physicians. Younger doctors are not going to work like we worked. I interview orthopedic surgeons for orthopedic practices in part of the consulting work that I do. And these guys are coming out of practice, and they don't want to take call on the weekend. They want to be with their families, and they want to be a partner in 2 years. Well, as we say in Texas, that dog won't hunt. It's not going to happen. You have to go out on your own, and if you want to do that, then go out on your own and be your own person. If not, get in line. Go work for a hospital where you can and will work 9 to 5, but not by what you've learned, but by what you've been told. So as I said before, we'll have a lot of accessibility, but we will have no availability. There are 50 million people in Medicare in 2012. There were $510 billion in projected expenditures and $474 billion in revenue. Well, that's a $36 billion deficit, folks. So we go to the lockbox, where there's only $344 billion in assets, and we take out $36 billion, or greater than 10%. Do the arithmetic, it's not math, and we're in big trouble with Medicare. What does the Affordable Care Act do? Well, it reduces Medicare expenditures by $760 billion on the supply side. There are going to be huge reductions in hospital and physician funding. We all know that's coming. And guess what? There's no longer Medicare funding for education and training. And what's left will go to specialty care because it's more cost effective to train a specialist than it is to train a primary care person. The hospital will make more money. The hospital, whether it's a not-for-profit or a for-profit, will always make a profit, just like Aetna. So, over the next 9 years, and this was last year's figure, the projected cost increase was $1.7 trillion at a net loss of $380 billion in 10 years. Well, that's just not going to work. Now, the rest of these slides talk about how it's not going to work. The premiums are up. We all know that. We all know what's happening. The idea of holding costs down is nonsense. You cannot create an insurance policy that is not underwritten by risk. It doesn't exist. My insurance for this year decreased by $1,200 a month. And it decreased by $1,200 a month because I wasn't rated for my heart disease, which is a previously existing condition, and I should be rated for it. I'm not going to pay it, but I should be rated for it. And the insurance companies are going to get our tax dollars through the back door through a provision in the Affordable Care Act that will pay them for their shortfall so they will not fail. Most people don't know that. Worse, at least $100 billion a year is stolen from Medicare. The number is probably closer to $150 billion. And in 2012, the OIG and the FBI recovered an astonishing $6.5 billion of that. Now, in the real world, you'd get fired for that kind of performance. So what is the government going to offer us? Well, Henry Zhao, as you all might remember, made a statement prior to the exchange's opening, and he said, let's just make sure it's not a third world experience. Now, would any of you in your right minds practice medicine to that standard? This is what the American people don't know. Anybody fly a plane recently? The only thing missing are the chickens. This is the standard of health care that's coming. And you folks are getting out ahead of it. So in summary, we're looking at this environment where there are going to be 30 million more people in a system, the waits are going to be longer, insurance premiums are going to go up, the curve is being bent upwards like a colonoscope, physicians are going to become employees, and the ACA and American healthcare will offer us a third world experience. I would like to take issue with what the first speaker said when he said that the worst example of healthcare in the United States was Medicare. Well, I'll see your Medicare and I'll raise you the Veterans Administration, which is precisely what healthcare is going to be like. I spend 2 half-days a week at the Fort Worth VA, volunteering my time, doing compensation and pension evaluations for these kids who are coming back without limbs. And the system is unchanged from when I was a resident in when I was a resident from 1978 to 1982. So the question becomes, well, what do we do? Okay? Well, I like Willie Sutton. And Willie Sutton once was asked, why do people rob banks? That's where the money is. So let's look where the money is spent. Hospitals chew up 33% of the healthcare dollar. Administrative costs, and BIR means before reimbursement, actual reimbursement. The administrative cost a claim is 9%. Physicians only make 19%. If you ask your patients, how much do you think physicians make? They say 30, 40%. They don't know. So I said, well, show me the money. How am I going to create something by what exists in the environment, and how can I think out of the box? Well, most of the money is spent in hospitals, and hospitals today, I would propose to all of you, are extremely inefficient factories. They are essentially what the American car industry was in the mid-'80s. And Peter Drucker, who was formerly and previously introduced to you by the former speaker, went to Japan in the 60s, along with Bob Dodge from MIT. And the Japanese learned very quickly. And they changed the way they manufactured and produced cars, and the rest is history. So old hospitals are built for the way medicine was practiced years ago. And by the way, they're still building large hospitals. Technologically, we're able to get people in and out, do things by outpatient procedures that we haven't been able to do before. Why are we building these big hospitals that keep sucking money, not only from the patients, but from us? Why can't we control the factory? Why can't we control the place of production? Thomas Jefferson said, if you don't control the place of production, you can't control your life. There's no reason why we can't do it. You've taken control of your own personal factory. I say, let's think a little larger and see what we can do to really save some money and create an environment where we can again take control of our patients in the surgical sphere as opposed to the primary care sphere. And if you take a look at this curve, the gold line on the bottom is pharmaceuticals. The green line is outpatient care, and the blue line is inpatient care. And the dirty little secret that hospitals will not tell you is that when the rates for borrowing money go up and their arms are expired, they are going to owe a fortune on the money that they've borrowed for their stuff, for their bricks and mortar. And they're going to be under increasing pressure by the government by decreased fees. And there's going to be huge chaos, and out of chaos comes huge opportunity. So I would put to you that in 40,000 square feet, you can do over 90% of a hospital surgical product line, and I know for a fact that it can be done at 20% of the fixed cost. Now think about what that can do. Well, if you can do that, 70% of a hospital's revenue is from procedural medicine, and the cases can be done, as I said, up to 50% of the cost of traditional hospitals. If someone charges $10,000 to do an anterior cruciate ligament reconstruction, a small hospital can charge $5,000 and still make an incredible margin of profit. $710 billion is spent on outpatient surgery in 2011. What happens if we can decrease that amount of money, and what happens if we can give it back to people who can't afford to pay for health care? What happens if we can give it back to education? What happens if we can bring this small place of production, this new factory, into the inner city? A lot of amazing things. If you own the place of production, you can also control how you cost and price things out and how you administer costs. In Canada, it costs them 25 cents to process the same claim that costs us $1. Now that's absurd. The resulting savings is hundreds of billions of dollars, and those hundreds of billions of dollars can go back into providing health insurance, again, for people who don't have it. The last thing I want to talk about is what you've heard drips and drabs of today. I loved Dr. Nunabaker, I hope I'm pronouncing his name right, when he said, well, I had the patient send a picture to me of what a laceration looked like, and I said, oh, okay, come on over and we'll see it. Wow. I mean, why don't we do that? Do you know that you can now have an app for an echocardiogram? Did any of you know that? There's an app for that. And I calculated the savings, and the savings would be at least $8 billion a year. That's really incredible. The top picture is an ICU. The bottom picture is something that you can put on your wrist that gives you the same information that all of those instruments in the ICU gives you. And this is a wonderful book. I recommend it for all of you. Eric Topol, The Creative Destruction of Medicine. It again talks about creative destruction, starting at the end, working backwards. Here are some apps that you can get for diabetes. There's a little chip that you can swallow now, and it can give you just about every piece of information you need to know from blood work and from a lab. Why do you need a large office anymore? You need 200 square feet. You don't even need a nurse, as you know that. Telemedicine is coming. It's going to be incredibly successful. Again, you decrease the cost of doctors' visits, and more money can go to pay for folks who can't afford the care. And why can't we do this? Because creative destruction threatens the status quo. Nobody who has something to lose is not going to fight for it. And these hospitals are going to fight tooth and nail. But in the end, they're going to fail if we take the lesson from that one doctor who stood up to Aetna and said, no mas, ain't happening, not on my watch. And a line was drawn in the sand, and look what happened. And if you don't believe in creative destruction, look at this slide. It's not a zero-sum game, folks. Again, Mr. Drucker. A lot of incredibly great things can happen, and my challenge to you is to understand that the task before us is not to see what others do not see, but to think what nobody yet has thought about that which everybody sees. Thank you.